So we have this ganglionic cyst here. It's had for many years.
Yeah.
How's it feel when I press on it?
Uh-huh.
Does it hurt right here?
Yeah.
Right there.
Uh-huh.
All right, so we're finally going to get rid of this thing. We've drained it a couple of times. It keeps coming back.
Oh, just keep coming back.
Yeah. See how movable it is, a motile we call it. Pretty firm. How's it feel when I squeeze it?
Oh, yeah, it hurt.
Hurt? Yeah. All right, well, we're getting ready to give you the anesthesia, numb everything up. All right, and then we'll take this bad boy out. This cyst, which is a fluid, which then turns to a gel, can cause pain, especially inside of shoes. So we've drained it a couple of times and it came back. So today we're just going to remove it once and for all. All right, there we go. Alright, so just a linear incision right over the mass. Pull the skin up. This is bigger than it looks like. So we want to make the incision a little bit longer. There we go. There's no bleeding because of the ankle tourniquet. There we go. And as we separate the skin, we want to be sure that we do not cut into the cyst. Otherwise, we end up getting fluid all over the place. So, see how the mass is coming through here?
Oh, I see it. Right there.
Yeah, now right
Wow.
there.
Nice.
It's bigger than what it looks like.
It's big?
Yeah, it's pretty big.
Oh, wow. Wait.
It's always bigger on the inside than what you can see from the outside.
Uh-huh.
See that? See that?
Oh, wow.
It's like something from a movie. And it's kind of firm. See how it's almost kind of yellowish on the inside? Yeah. Think about ganglionic cysts, that they tend to grow back even after surgery. Got about a 50% chance of recurrence.
Oh, wow.
This is why most of the time we don't go through this unless it's, it's pretty painful for the patient.
You okay? You got
Oh,
that?
yeah, I feel it.
A little pressure.
It's fine. I feel it.
Okay. There we go. There we go. See, now it's within the... How we can really see it now? Because I want to identify where I'm going to use my blade to cut it out. I just don't want to just go willy-nilly in there and just start cutting stuff out. So you see here? Here's an end.
Yeah, I do.
Right there. This the one. Then here's the other end.
Oh, I see it.
See, what you see is that it's kind of long on this end. That's the tendon.
It looked like it too.
Yeah. So what we have to try to do is to separate the mass from the tendon
So you don't cut the
so we don't cut the tendon. We want the tendon to stay functional. All right, so I'm holding it there. See all that? Just separating. And there it goes. So you see why I was so mobile, so modal. Because it's in here, so it's all over the place. So you look underneath it, it's just not, yeah, it's not involved in any of the deeper tissues. See, there's nothing going in from the bottom. So here's the bottom of it, right here.
Right.
All right. So you always want to identify all the boundaries of a mass before you remove it.
Makes sense.
Otherwise, everything's fine. Patient comes back in 2 months because it's returned. And sometimes they return with a vengeance.
Attached to something else. than the
That
original.
or bigger than before.
Oh, wow.
So I'm trying to separate as much of it bluntly and just use the blade a little bit.
Which is even better for the patient.
Exactly. Because the more blunt dissection, the less pain the patient will have after surgery, the less scarring the patient will have after surgery. All right, so I think I have identified all of it.
I think so too.
All right, so I'll start on this distal end. All right. All this fat around it. All that off. So it's in there pretty good. So see the stalk? As close to the mass as possible. Okay. Here's that end. See how the mass is sitting out there now? Yeah. And there we go.
Nice.
All right. Well, first, we'll do the deeper tissues so we don't end up with a pocket full of fluid. And then we'll do the skin. There we go. Hmm?
Tuesday?
Yeah. And so this stitch, the first one, will be broken down and absorbed by the foot over the next few weeks while it holds everything together. We call this an absorbable stitch. Alright. Now we do the skin and we are done. This will be removed in 2 to 3 weeks. It's not absorbable, it's non-absorbable, so it helps keep its strength as the skin heals up. I'm doing a horizontal mattress pattern here to help keep the edges together. Yeah. Okay. Here we go. Well done, buddy.
Okay, thank you.
You're welcome.
God bless you.
This is Dr. Kevin Jefferson, the DC Foot Doctor. Thank you for watching this video. Like it with a big thumbs up and subscribe to the channel. Also follow me on Facebook, Instagram, and Twitter at DC Foot Doctor. And most importantly, take care of your feet.